Ladies and gentlemen, thank you again for inviting me to this wonderful meeting, and please accept my apologies for not being able to attend in person, but I promise next year I will. So my first lecture at a meeting is the IVF placenta, which in my view is the only evidence-based obstetric complication of ART, direct complication. I have no conflict of interest to declare in this context, and I will take you through this lecture starting with congenital anomalies. And the first time I met Professor Bob Edwards in the 1980s, he was still fighting the establishment because everybody told him that the fetuses resulting from IVF were all going to be abnormal and have some issues. And so when you look at the data from the last 35, 40 years, yes, there is a very slight increase in the rate of sex chromosome abnormalities associated with ICSI. Overall, there is a risk of major birth defect, but it is probably technique independent, and it's probably also linked to other external factors that affect the mother's fertility or the father's fertility. So overall, looking at the fetus, we have a relatively risk of all ART being associated with a birth defect, which is about 1.37, which is 30% above the non-IVF pregnancies. These affect mainly the central nervous system, where the father's age plays an important role. And there's no difference really in between the different IVF techniques. If you compare ICSI with no ICSI, you see that it's only a 5% increase in the risk with ICSI, which is linked, as I showed you in my previous slide, to sex chromosome abnormalities, which is a very rare complication, even in ICSI. Now, you have to always look at the background, and there is a possible biological link with the aspect of the IVF procedure, the culture medium, the length of time in culture, the freezing, the underlying cause of infertility, which is never included in the big epidemiologic studies on any of the complications linked to IVF. But there is some evidence that there is increased evidence of subfertility in couples who have this condition to have increased risk of birth defect. Now, let's have a look at another organ of the fetus, which obviously is the placenta. And for this, there is absolutely no doubt that there is an impact of IVF technique on the risk of placenta previa. It's less clear when it comes to placenta accreta spectrum, but there is also a risk of anomalies of the cord insertion. Now let's start with placenta previa and IVF. I mean, the early studies of large number of ART pregnancies, like this one published in Human Reproduction in 2014, show that there was an association between the endometrial thickness before the embryo transfer and the risk of having a placenta previa. And these differences remain statistically significant after adjusting for parity, smoking, or endometriosis. But it's not clear from that study if all the cases included were IVF. And of course, there is no description of the ultrasound diagnosis of placenta previa and at what gestational age this diagnosis was confirmed, or if it was confirmed at birth. And this is one of the main weaknesses of all the studies on placental and maternal complication associated with IVF. Now, this is a large study from the Nordic countries showing that the risk of having a placenta previa after ART is about 4 times what you will find in non-ART pregnancies, which is about 3.87 in this study. But again, you have no indication that these pregnancies were IVF, or if it's frozen embryo transfer or fresh embryo transfer, absolutely no indication of the technique used. And of course, again, no confirmation of the diagnosis on ultrasound or at delivery. and what type of placenta previa we're dealing with, or if it's a low-lying. So anyway, if you look at the whole literature, this is something we did in 2020, there is clearly an indication that there is an association between IVF and placenta previa. Whatever study you look at, whatever systematic review you look at, you have this increased risk, which goes, from 3.7 to some studies reporting a risk as high as 6 times what you will find in a non-IVF pregnancies. But none of these studies include, as I said, any data on the infertility causes that necessitated the IVF, but also no data on prior cesarean section. And this is an important parameter because there is a clear association between a previous cesarean section delivery and the risk of having a placenta previa in the next pregnancy, which is increased by 74% compared to the patient in the control group that didn't have a cesarean section in the previous pregnancy. So a prior C-section is definitely also a risk factor, which means that if you combine IVF with an odds ratio of about 3 to 4, higher than in control non-IVF pregnancies, if you add to this the risk of cesarean section, and the risk increase with the number of previous cesarean section. For one prior cesarean section, you already have a risk that's increased 5 to 8 times compared to pregnancies that are not IVF and have had a normal vaginal birth in a previous pregnancy. So yes, so this is really a high-risk group that we need to take into account when we provide these patients with antenatal care. There seem now to be new data showing that the type of IVF technique and the use of fresh versus frozen embryo makes a difference, because you see that this study has shown, it's again a large Nordic study, that there is a high risk of placenta previa compared to spontaneous conception, where we knew that, but the fresh blastocyst transfer, it's one of the highest rates I've ever seen in the literature on the link between placenta previa and an IVF technique. But it is also higher than the frozen embryo transfer. But again, in this study, you have absolutely no description of the ultrasound diagnosis criterion for placenta previa, and in particular, at what gestational age were they, collected. So why is this happening? I will always ask my question, and this is my own hypothesis. I mean, it took me years to look in the literature and finding a plausible cause, is that there are clever studies from the 1990s showing the effect of microuterine contraction that the patient will not feel, changing direction, going up during the first phase of the cycle, possibly to bring the fluid inside the endometrial cavity and the sperm closer to the tube, so allowing the fertilization. And then in the second half of the cycle, you have these microcontractions that are bringing the fluid down, because it has to bring, of course, the period blood outside the uterus. And so you have a change in the direction of the flow between the first phase of the cycle and after ovulation, and progressively downwards after ovulation towards the end of the cycle and the menstruation, which means when you transfer your embryo, of course, with your catheter, you try to put this as close as possible to the fundus of the uterus. Most centers know transfer blastocyst day 5, which means that it is already starting to interact normally in a natural cycle with the decidua, the endometrium transforming into decidua, and with the fluid going in downward. You can imagine that even if you put your catheter here, it will fall down inevitably. And I think that's probably the main reason, the lack of interaction between the blastocyst being transferred on day 5 and the normal uterine environment, and the fact that the fluid goes down, that increase the rate of placenta previa in these pregnancies. So what about the link with placenta accreta spectrum? Yes, you will also find in literature an increased risk in IVF pregnancies, But you have to take into account that you are dealing with IVF pregnancies who have a low-lying placenta anyway, or a placenta previa more commonly. You're dealing with patients who tend to have a more advanced age, which means that they're more likely to have a previous cesarean section, and none of these studies include these data, which means that indeed, if you have a patient that has IVF after a cesarean section, she has a high risk of also having a placenta previa with the pregnancy implanting inside the scar, particularly if there is a scar defect, which affects about 40% of the patient after cesarean section and increase with the number of cesarean section. Fortunately, 50% of these scar ectopic pregnancy will miscarry, and therefore not all of them will transform a placenta previa accreta, but they're definitely very high-risk patients for this condition. But it is not the IVF that's responsible directly for that. It doesn't make the placenta more accreta, more susceptible of going into a scar. It's just bad luck because it increases the low placentation. And finally, the anomalies of the umbilical cord. There's also a lot of literature on this and IVF. We know that in the general population, the prevalence of vasa previa, which is commonly associated with a filamentous insertion of the cord, is about 1 in 1,200, but it is rising quickly with the number of IVF pregnancies and the number of cesarean section, which increase the risk of having a low-lying placenta, meaning that you also have a high risk of having a cord implanted closer to the lower segment, and therefore the risk of vasa previa. You may know there are actually 3 types of placenta of vasa previa. I'm not going to go into the details, but what is important is to identify those patients that have a filamentous insertion cord, because 3 to 4% of these patients will have a vasa previa, and this represents the type 1, which is the most common condition associated with a vasa previa. If you look at the epidemiology, we did that recently for a new version of the RCOG guideline on vasa previa. You see that pregnancies resulting from ART have the highest level of evidence of an association with vasa previa.